All right, so here's our test 3 review. How you guys feeling for it? Pretty good?
Good until this last section.
Good until this last section. This is... Baptizing over the weekend? Does anyone have any questions prior to meeting started?
Okay, starting off with GI, what does the abbreviation DR stand for in regards to administration?
Usually delayed release. Can you tell me the context that you saw, the DR?
So, for the mesalamines,
Yeah.
for acetal,
Mm-hmm.
pentacid.
Yeah, you'll find with the salicylic acid products, there's a lot of different dosage forms, and many of them are just kind of variations on delayed release, controlled release. They're just long-acting forms, so that way they have a chance to kind of get through the entire GI tract.
So are those, in terms of the mesalamines, the pentacid and roaza are corrective, so they're preferred for ulcerative colitis. The first three, acetyl and pentacid, are they prodrugs?
They're all kind of prodrugs, right? So they're all being converted over to that 5-amino-salicylic acid to some degree. So they're all working very similarly. It's just a matter of how they're getting to their site of action, right? And so even though you say that, yeah, the enemas and the suppositories are good for ulcerative colitis, it's really only good for really the kind of distal ulcerative colitis, right? Especially if you're looking at like enemas, they have a lot better penetration than you would say have for like a suppository, right? Because it's just a matter of where's the drug actually going. So if it's, just a proctitis, then, maybe a suppository is all you need, versus if it's going to be a kind of a pain colitis, that's going to require oral therapy because, your enemas aren't going to get that far through the colon. Sulfasalazine?
Sorry. Is that, it's a prodrug, but it's not systemically absorbed, or it is?
It would also not be systemically absorbed. Like, it's really working more kind of locally.
So none of the aminosalicylates are really...
You may get some systemic absorption, but like not to such a degree that you're going to see a ton of systemic side effects. That's why they're really preferred as kind of your first-line agents, because they're not going to have a ton of systemic effects as you're going to see with something like a methotrexate or a 6-mercaptopurine or something like that. So that's the benefits of using them. And why you might want to use like a topical, say like a rectally administered hydrocortisone versus like an oral corticosteroid, because you get better local action, not a whole lot of systemic side effects.
Versus the sulfasalazine. One of them has less side effects, but it's like breaks down into the two base compounds.
Yeah, so they're being broken down to the 5-amino-salicylic acid, right? So don't get too hung up on like one versus the other, like when you might want to use one. A lot of it depends on the patient. I usually end up seeing a lot of them being put on the 5-amino-salicylic acid products, like the mesalamines and things like that first. Sometimes you'll see the sulfasalazine being added on as a secondary agent. Sometimes they'll switch over to one. It just depends on the GI provider and how the patient responds.
So the side effect profile
Should be relatively similar, yeah.
I had another question. Can I get clarification on like this vitamin D supplementation in chronic kidney disease?
Yep.
Just in general, it's like you need the vitamin D, but the kidneys break down a couple of the drugs. So are we not giving those, or we are giving them, but it may not be converted as well? Versus what was the other?
Okay, so what's kind of the issue with vitamin D in chronic kidney disease?
That's not being produced.
Yeah, it's not being produced very well, right? And so we'll talk a little bit more about this as well when we get to the endocrine section. It'll come up again for sure when we talk about calcium homeostasis and things like that. But just when we talked about it here, the big point is that you have issues with calcium homeostasis with chronic kidney disease. You have issues with vitamin D synthesis, right? So if I give you regular, say, ergo or cholecalciferol, which are vitamin D derivatives, are those the active form? No, right? So why are they no good for chronic kidney disease patients? Good. So where are the two places that the vitamin D gets converted to an active form?
Skin. Not skin.
So a little bit of it gets started in the skin. So the kidneys is the final step, right? So there's these two hydroxylations that occur to the vitamin D. The first step happens in the liver, and then it goes down to the kidneys to get the final hydroxylation. So that's why you see that I don't remember the numbers, but it's a 2 hydroxylated The calcitriol is. And so when you have that activation in the kidneys, that's the active vitamin D. And so if your kidneys are poorly functioning, then they're not going to produce that. So that's why we give the already activated form. You're not giving those forms in addition. Yeah, I'm going to pause it real quick just so. Okay, right. So we're not going to give ergocholecalciferol in those patients because it's not really going to be all that useful to them. Next question.
So with the hyponatremia stuff, under your slide it says euvolemic hypotonic hyponatremia, and here you said that increases total TBW and ECF volume. But then on one of your first slides you said that hypotonic solutions is when it's a decrease in the ECF. So I don't really understand why it says that it's an increase here.
So if you were to I have a few slides on that, so let's hold on to that one until I go over those, just so I can show you on the slides itself. Hopefully that'll make things a little bit clearer, so hold on to that one.
So with the ergocalciferol, since it must be converted, it's not going to be useful for CKD.
Yeah.
Okay. So what would we use for vitamin D in those patients?
That's where you use the calcitriol.
Okay. Now.
Oh, go ahead. Sorry. Just wait your turn. Just kidding.
It says that it's going to lead to hypercalcemia and hyperphosphatemia and more progressive disease. So, like, what's the...
Right, so what's the counterbalance, right? So, basically there's these feedback inhibition loops that are happening, right? So the parathyroid, they're sensing for both vitamin D and for calcium, right? So the parathyroids, they sense they don't have enough of either, then it's going to start to secrete more parathyroid hormone, right? Parathyroid hormone is responsible for helping to increase generation of vitamin D. It's also helpful for increasing uptake of calcium and also getting the osteoclasts to start working on the bone, to have the bone resorption, right? So by giving the activated vitamin D form, that's going to be able to have a feedback loop to help inhibit that. The problem you're going to see, though, is that by giving more vitamin D, you're also increasing calcium levels, right? So there's kind of an interplay there. Early on when you're having chronic kidney disease, you typically have a hypocalcemia because the hyperphosphatemia develops first, and that binds up all your calcium.
Because it leaches from the bones and all that.
Well, the parathyroid hormone is what's helping to leach it from the bones, right? So that's why you worry about the osteomalacia that can develop over a long period of time. But initially, when you just have normal levels of calcium floating around the serum, the high phosphate levels are going to what's binding it up, right? And so that is signaling back to the parathyroid. I don't have enough calcium. Let me start to produce more parathyroid hormone, right? So there's a balancing act, right? So that's why we do things like we inhibit the amount of phosphate they get in their diets by limiting, like, colas and meats and things like that. But keeping in mind that patients with chronic kidney disease oftentimes have higher protein requirements because, again, they can be have issues with malnourishment and things like that. So it's all a delicate balancing act. Some of those patients end up getting parathyroidectomies and things like that just to totally just kind of shut the whole system down, and then they can replace things as needed. So it's complicated, but just be aware that we give that activated vitamin D form because the kidneys can't produce it on its own. So we can give precursors all day long, but the kidneys can't do anything with it.
Okay.
Yep. Okay.
I had a question about phosphodiesterase inhibitors. All 6384 metabolized.
If you go back to the slide that has it on there might be one or two that are not, but just be aware of the interaction. That's one of those things where just run the interaction checker before you start adding on meds to make sure to double check that.
And then it was slide 60 of part 2 of the renal. It said that phosphodiesterase inhibitors should be avoided in healthy patients. Is that a typo?
No, so don't use them in patients who don't need them. Recreational, right? So that's a big problem, especially like I mentioned in the slides, but in a lot of hospitals they treat it like a controlled substance because they worry about staff stealing, right? So like even in a children's hospital, we end up using a fair amount of it because we use it in a lot of our pulmonary hypertension kids and cardiac kids for the vasodilatory effects that it has. So for a while we held it as a controlled substance, and we finally just kind of got over. We didn't want to deal with it anymore, so we kind of deregulated, I guess you could say. But yeah, so you don't want to give for healthy patients who don't really need it.
Okay, and then second and third generation alpha-1 antagonists, same efficacy.
Yeah, so then at that point you're looking at costs versus side effects and things like that, like the like the tamsulosin might be more expensive than something like just a regular alpha-1 antagonist. So you may see some issues there where, you know, say cost is a problem and the patient can't afford it. So equally efficacious, but the more specific one, just antagonizing the alpha-1A receptor, is going to lead to less systemic side effects, especially like blood pressure and things like that.
One more question. If the patient has hypokalemia, you want to give them MAG as well with potassium?
If they are hypomagnesiemic, then you would.
So you wouldn't give MAG and potassium if they're hypokalemic?
Not always. It depends on what their magnesium level would already be. In a lot of cases, if you have patients who are, say, like on chronic diuretic use, or if they have electrolyte wasting conditions or something like that, you very well may need to replace both. And a lot of times, I think people don't check magnesiums often enough, because when you do a basic metabolic panel, you get potassium on there, but you don't oftentimes get magnesium unless you add it on, or if you get a complete metabolic panel. So very frequently people will say, hey, I can't get this patient's potassium corrected, and a lot of that has to do with how the kidneys handle potassium. They also require magnesium to do that as well. So we run into issues. Yeah, they're interconnected in the kidneys to some degree. That's why a lot of times when we have patients who we are trying to serum alkalize. So say, for instance, you have a patient who had overdosed on a tricyclic antidepressant. One of the antidotes that we do is we try to alkalize the blood to a pH of, say, 7.45 to 7.55, right? So we try to bump up their serum pH in order to help treat that overdose. We're not going to get into details on that. But one of the problems is they oftentimes will get hypokalemic because of the alkalizing the blood causes an inward shift of potassium into the cells. But then also it's hard to alkalize when you don't have enough magnesium around as well. So like, they're all kind of playing with one another. It's important to check magnesium if you're concerned about it. All right, I'll get back to you. Yes?
I have the acute kidney injury.
Mm-hmm.
So, if prevention isn't beneficial, do we still do it?
So prevention was what?
Vasodilators, antibiotics.
So I will tell you that even though there are not a ton of studies to back a lot of those up, it depends. Because right, medicine's gray. Not really going to be black and whites for everything necessarily. So look at the risks versus benefits for your patient. So for instance, we had a child who was in the PICU who needed to have a CT scan, but they were having very, very poor kidney function, right? So we know that, you know, giving those contrast agents can have the potential to fry their kidneys even worse, right? So we kind of have to balance, like, well, we need to do this imaging on their head, but that we don't want to fry the kidneys any further, right? So at that point, you know, the nephrologist was consulted, and he came in, he said, well, you know, let's just do N-acetylcysteine. And so there's not a ton of evidence back there, especially in pediatric patients, to say that this is going to prevent further kidney injury for this patient. But what are the side effects of giving the N-acetylcysteine? Not really a whole lot, right? Especially if the kid can drink it, doesn't have any nausea vomiting with it, it's not really going to hurt them. So we gave a couple of doses, say 24 hours before through the procedure, and then say 24, 48 hours afterwards. You know, did it actually prove any benefit? Hard to say, right? We could have given him nothing, and then, you know, we could have just hydrated him really well, and that could have done the same thing for all we know. So it's one of those risk benefits. If there's really no risk to doing it, some patients, and especially high risk ones, may opt to go ahead and do it anyway.
And when you talk about renal replacement theory, are you just referring to dialysis?
Yes, anything that is we are taking over the kidney's functions with a machine, right? Whether it be hemodialysis, whether it be peritoneal dialysis. You guys kind of get the difference between those two. Have you talked about them before? Yeah, so I thought it was a good picture. Yeah, anytime we're taking over the function of the kidneys, that would be renal replacement therapy. And there's lots of other types. You know, there's veno-venous and veno-arterial and arterial-venous. You know, how they actually get the blood out and back in can change based on the type of modality, but essentially, you know, it's all renal replacement therapy as a large umbrella. Yep. Any other questions?
So, are you going, did I see, like, did you see your questions?
Hmm?
Did I see?
Yeah, I'll save them until we can kind of look at this, because I knew that that's usually a hitching point for a lot of people, so we'll talk about that in just a minute. A hitching point, people get trouble getting over that hurdle. Any other questions before we get started? Sure.
Between calcitrol and carrot.
Mm-hmm.
Why would you use one versus the other? Because one is saying it activates the PTH receptors. Is that not going to cause?
Yeah, so so the calcitriol is the activated vitamin D form, right? So it's already the hydroxylated form that we can give, where the kidneys don't have to do anything with it, liver doesn't have to do anything with it. The pericalcitol is oftentimes given to sensitize essentially the PTH receptors to the calcium and the vitamin D you already have in the bloodstream. That way it kind of gets the, because one of the things we mentioned in chronic kidney disease is that you oftentimes get this kind of resistance where the parathyroid hormone is not really able to sense calcium and vitamin D quite so well. So by sensitizing those receptors, it's able to kind of shut itself off a little bit better, right? Because the big thing you're doing is like, I just want to stop that bone resorption. I don't want to cause further bone damage than what's actually needed. Cool.
So, use the prostaglandin E. Is it a suppository?
Okay, so the Caverject, right? So there's two different. The Muse, right? So there's two different dosage forms, right? So one's an actual injection, and the other one would be a suppository to actually put in the urethra.
Sounds pleasant.
No, it's about yay big, and yeah, so that'd be pretty small. It's kind of like a little pellet size kind of thing from what I've seen. It's not pleasant. That's why I'd rather just pop a pill and be done with it, right?
Yeah.
I want to inject myself. Sometimes you gotta do what you gotta do. Sometimes you gotta, those nitrates on board. Sometimes not having a heart attack is possibly better than the alternative. So
I don't know.
depends on who you ask. That's why you have to have conversations with your patient, find out what's important to them. Okay. So anyway, I'm glad you had lots of questions. I didn't want you to be like this kid here.
I said that to you yesterday.
So okay, well, we're not like him. So anywho, so important points to cover, the GI stuff. So looking at treatment of GERD, it's important to remember the medications themselves that can cause GERD. So remember that a lot of things that will dilate smooth muscle, things like, our calcium channel blockers can increase GERD because it helps to lower that lower esophageal sphincter tone, things like that, things that can upset GERD. Know the mechanisms of the various agents, so be able to identify, how famotidine is going to be an H2 blocker versus omeprazole is a PPI versus, magnesium hydroxide is going to be an antacid. Like, know the mechanisms there. There are different adverse effect profiles, how they're going to differ from one another, and why one might be better for a patient than the other. What are some particular side effects for PPIs that you might worry about, say, in a patient who, say, older, say, a little tiny old lady? What are some of the issues you might worry about using a PPI in that lady? Why osteoporosis?
Decreases calcium absorption.
Exactly, right? So you worry about calcium absorption when you're mucking around the pH, especially with something as potent as a PPI. So that can worsen osteoporosis, maybe make some of their other medications not quite so effective. What it would be a concern if I'd say like an intubated patient in the ICU who's on a PPI?
Aspiration of
Yes, you said VAP, right? So why VAP?
Because it lowers the acidity, or higher the acidity, that's why more bacteria grow.
Right, so it makes it more alkaline in the GI tract, and so it makes it more favorable for bacterial growth, right? So then you can have microaspiration of bacteria and then develop pneumonia, right? So that's one of the big things you worry about, kind of the double-edged sword of using PPIs, because you also worry about stress-induced ulcers in the ICUs as well. So you really need GI protection, but then you have to kind of counterbalance it and make sure you're doing like good oral hygiene and things like that to prevent infection. So it can be an issue there. Yeah, and just know their place in therapy. So obviously, if you had someone who was having very consistent symptoms every single day, what would be a good therapy for them? PPIs would be good. H2 blockers would be good. What about like antacids?
Maybe for like
24-hour coverage.
Yeah, good. So for acute episodes, if you just have, a really big spicy meal, that might be a good option for them. If they just have really intermittent symptoms, but continuous use, yeah, one of those other two classes would be better.
Because the H2 blockers only work for like 3 months, are they, is that when you jump to a PPI, they just keep having these symptoms?
Yeah, so it's not that it only works for 3 months. I mean, you can keep using it beyond that for sure. It's just if you're not having symptom improvement and you've kind of maxed out your dose, then you can switch over to a PPI. Yeah, so if you don't get control of the H2s, then you can switch over. Yep. Okay. How about management of ulcers? So if I were to have someone and I diagnose them with H. pylori, what would I use to treat them with? So 4-drug regimen. What's in a 4-drug regimen? So PPI, Pepto-Bismol, and 2 antibiotics. What are some examples? Tetracycline, Flagyl or metronidazole. Any other ones? Clarithromycin might be one. Amoxicillin's in some of the regimens, right? So just realize you're using multiple antibiotics with usually PPI, usually bismuth-subsalicylate or Pepto-Bismols can all be useful. Why do you use a 4-drug instead of like a 3-drug regimen?
It's like 97% versus 70 to 80.
Yeah, so you're more likely to get better kill rate for that. You're better to clear the infection.
So you can use more than just metronidazole and tetracycline for the 4-drug?
Yeah, I think that's what's most often recommended. But certainly if you had like issues where the patient was getting better, you may need to switch out antibiotics so there was like resistance happening or something like that.
And is it any 2 of the 4 antibiotics, or is it like a particular?
Like I said, usually go with what's on the slide as far as the pairing goes. Like I said, you may change based on allergies. You may change based on sensitivities of the bug. If you have like really resistant cases for whatever reason. Yes. Yes, be able to just know that yes, these are the components that go into the regimen. I'm not going to sit there and give you 2 choices and one of the antibiotics is incorrect and expect you to pick that. So that's kind of mean. So just be aware of what goes into the regimens, right? So if we put like a beta blocker plus the phosphodiesterase inhibitor, well, that's not the right regimen, right? So. Okay. What about if they were on an NSAID chronically? What would you do? Stop. Okay. So what could? Okay. Why Celebrex? Specific for what? COX-2. And what does that do? It doesn't inhibit production of prostaglandins. Why is that good? I mean, ibuprofen does that too.
It's going to lower the acidity.
It doesn't affect the gut?
Prostaglandins.
More protection.
Secrete mucus.
Right. Yeah, so prostaglandins are useful for developing that mucus barrier on the stomach, right? So if you don't have that barrier, and which cyclooxygenase is useful for producing that? COX-1, right? Because that's the constitutive enzyme, meaning it's always being produced in your body. COX-2, on the other hand, is what? It's not always being produced. Inducible. Absolutely. Inducible enzyme. Right? So if you have an injury, if you have inflammation somewhere, that's where it's going to be working at, because that's where the enzyme is going to be upregulated. So by giving a COX-2 selective drug, you spare the COX-1 being used to produce that gastric barrier, right? So again, initial first thing to do is take them off the NSAID, and then what could you put them on to help with the healing? What help with the healing of the ulcer? Okay, right. So I could, so I could put them on misoprostol as a cytoprotective. What would I do maybe before that? A pregnancy test. Okay, so maybe before I get misoprostol, I would do a pregnancy test. But before I consider putting them on prostaglandin, what would I? H2 blocker, PPI, yeah, any of those are going to work to help decrease that acid secretion to make sure we can help to give us a chance for that ulcer to start healing. Perfect. Okay, so then looking at antiemetic. So let's say I am super sick, I'm nauseous right now. What kind of drugs do you want to give me? Zofran, okay, otherwise known as? Ondansetron. I think about like a funky robot for some odd reason. That's how I remember it in my head. Right, so ondansetron. So how does that drug work?
Serotonin.
Right, 5-HT3, absolutely. So 5-HT, it's important to have the numbers on the serotonin receptors because you'll find that when we do like migraines, like 5-HT2 receptors are important there. So they are, out of all the neurotransmitters, that probably has the most wide ranging of different receptor subtypes. So we'll do 5-HT3 receptor antagonists like ondansetron, or what's another good example? Yeah, dolasetron. Granisetron's the other big one. So I probably see granisetron being used as a backup if ondansetron's not usually working, especially on chemo patients. So I can use those. Any side effects I should be worried about? Yeah, QT prolongation is probably one of the big ones, right? So especially imagine if I had a patient who had recently had a bone marrow transplant, who was on immunosuppressives for that. Some of those can cause QT prolongation. I put them on a fluoroquinolone because now they have an infection because they're so immunosuppressed, and now they're nauseous. Yeah, so everything can prolong the QT after a while, and so that's one of the things you need to keep in mind when you have multiple medications on board, or if they have a congenital prolonged QT, right? Okay, so let's say I don't want to take Zofran, I want something else. What can I take? Finnegan? Okay, what type of drug is Finnegan? So it's anticholinergic, right? What else does it do? Right, so we say antimuscarinic. There's another receptor it's going to hit too. A little bit of histamine. One other one. Yeah, D2. So dopamine is going to be the other big one.
So you have to give something, right? Like so, that gives you. No, I'm thinking something else.
No. Okay, so right, so those drugs. So a lot of the kind of as a class, and we'll talk about those when we get to the psych section. But they're called phenothiazines essentially, and so they can kind of fall in that category of first generation antipsychotics. So even Finnegan kind of falls in that same family. So one, it's working by the antimuscarinic actions, right? Similar to how something like scopolamine or transderm scope works. Similar to how like Benadryl can even be useful for some nausea, vomiting. So that's antimuscarinic effects. What type of side effects would I expect from that drug? Yeah, so dry mouth, also known as? It's another name for dry mouth. Xerostomia, yep. Right, so what other side effects? You said? Mydriasis is good. Confusion, yeah, so they can be mad as a hatter, right? So usually it starts off with sedation. They can get to more excitation, seizures can happen. Anything else? Yep, so they can be hot as a match, right? Constipation, right, because it slows it down the GI tract. That can occur as well. What do you think it would do to heart rate? It should go up, right? As antimuscarinic should increase heart rate. Good. What about the D2 effects? If I block the dopamine 2 receptor, what could that do? Yeah, so we were about Parkinsonian type side effects. There's another drug that was really big for that in the antiemetics we talked about. It also had prokinetic properties. Yeah, Reglan or metoclopramide. That was the other big one. I remember talking to one of my hem-onc pharmacists when I was an intern, and she was saying that these cancer patients, they would get so nauseous, and you give them just huge doses of Reglan because that was all they had before Zofran came out, and they would just have all this pill rolling, and they would have this disturbed gait and shuffling, all of that. And they said it was horrible, but again, risk benefits of feeling like totally like how great do you feel when you're nauseous, like. Horrible. So yeah, so that was a big problem for a long time. So those are the major side effects you'd be worried about with those drugs.
I'm a little confused because you have Finnegan under just antihistamine on here.
Yep, so you will see that when we look at the antipsychotics, there's kind of a range. We talk about low potency and high potency agents blocking the D2 receptor. So don't get too hung up on that right now. Just know that it does have some dopamine blocking effects, which can also have sedative effects as well. That's why we give patients who are like really agitated in the ER, like like benzodiazepine, we give them a Haldol, which is one of those type of drugs, and it just knocks them right out. So yeah, so sedation can be a big thing you see, especially like Finnegan, especially a lot of those antimuscarinics. Okay, is there any other drugs I can use for nausea, vomiting? Forget anything? Cannabinoid. Okay, so what drug do we have for that? Marinol, which is otherwise known as, what would be the chemical name? THC, which stands for? Stands for marijuana? No, it does not stand for marijuana. Tetrahydrocannabinol, right? Delta 9 tetrahydrocannabinol, right? That's going to be important, especially when we start to talk about medical marijuana, because that's going to be important. I might touch on that more in Pharm 2 when we start talking about pain management and things like that. So that'll be kind of a hot topic. But yes, so how do those work?
They go to the brain.
They work in the brain. What type of receptors? So yes, they work in the chemoreceptor trigger zone. What type of receptor zone? It's a cannabinoid, so it works on in the CTZ, but what type of receptor does it hit?
D2?
The cannabinoid receptor, right? CB1. So that's a receptor that is its own specific receptor, right? CB1 or cannabinoid receptor 1. Right. Right. So any side effects I can expect with that drug? Yep. Get the munchies, right, which can be good in especially cancer patients or they have wasting syndrome. Anything else? Yeah, the mood changes, kind of depressed mood, things like that. So just like you might, I'm sure everyone has seen someone high at some point in their life, kind of like that. Maybe not. I don't know. Maybe I hung out with the wrong crowd. Who knows? Okay, so then moving on to laxatives. What are, give me a class of laxatives. Osmotic. Okay, so what are some examples of osmotic laxatives? Mannitol's a good one. What else? What's the main one we're going to be using in therapy nowadays?
Go lightly.
Go lightly, which is?
That was
That was right.
Polyethylene glycol.
Polyethylene glycol, yeah. PEG, polyethylene glycol, Go Lightly, Miralax, all those products are osmotic, right? So how do they work?
They increase water absorption.
Yep. Draw water into the colon. That helps to, tell the GI tract, hey, let's start sending stuff along. Perfect.
Do you know they have a half-life?
Have a half-lightly.
Yeah.
Is it just like less electrolytes in it, or?
I guess so. I don't know. I was like, I never heard of that.
Did I ever
guess
tell
it's
you-
not as potent.
Did I ever tell you about Go Darkly? So it's a tox thing where basically if you had someone who had ingested a lot of like drug packets or something, like so if you had like a body packer who was trying to get stuff in through say over international borders, you give them a dose of charcoal, activated charcoal beforehand, which is black, so that way if any of the packets ruptured it would bind up the drugs, and then you give them Go Lightly afterwards to flush things through, and so then the charcoal is also kind of a tracer, so once it starts coming out you've kind of hit through the entire GI tract, so call it Go Darkly instead of Go Lightly. Okay, so we have your osmotic. What other types do we have? Stool softeners. What type of stool softeners do we have? Docusate's a good one. Cholates, which is kind of docusate.
Glycerin.
And glycerin can be another one.
Mineral oil.
So do you guys know anything else you can use docusate for?
ear lavage.
Ear lavage, absolutely, yeah. So if you have like impacted cerumen in the ear, you can put that in there, let it soak for a minute or two, and then take that out. So we do a lot in the PED for sure. Right, so those will help to kind of lubricate things up and help get it moving. Certainly, we tried giving carrots to my 6-month-old, and 4 days of grunting, nothing's coming out. So we said, let's try giving a little bit of glycerin suppository, and sure enough, works extremely well. So anywho, what other classes do we have?
Opioids. Did you say antidiarrheals?
No, we're talking about laxatives.
Oh, my bad.
Bulk forming. Okay, what are some examples there?
Metamucil.
Metamucil.
Citrusol.
It's like psyllium husk, things like that, or basically your soluble fibers, or insoluble fibers. I'm sorry, that you can take. Lots of over-the-counter products that can be useful. Any side effects with those drugs?
Bind drugs.
Yeah, they combine drugs, so you want to separate those out. So that's important. Anything else?
Flatulence.
Yeah, flatulence, bloating, things like that. So kind of, any of these can potentially cause some GI upset because again, they're trying to help stimulate things to move along. Good. So bulk forming, should I use those for say IBS with constipation or diarrhea? You can use them both. Yeah, bulk forming are going to be good for both. They're kind of like equal opportunity players. In some cases, they can help to kind of draw water into the colon, similar to how an osmotic can help to kind of do the same thing to help push things along. So they can be useful for constipation, or they can kind of help draw in a lot of the excess water already in the colon with someone who's having, like, say, copious diarrhea, and can help to kind of solidify things a little bit for later defecation.
I have a question about that.
Mhm.
When we're talking about the laxatives, in both for constipation and diarrhea, are we always trying to get water into the colon?
If you're trying to move things along, generally, you'll find some things like the stimulant laxatives like Senna or Bisacodyl, they're going to be more kind of direct stimulants on the GI tract to kind of increase peristalsis.
So for the musculature itself?
Yeah, essentially. But then you also have things like metoclopramide, which are working, and like erythromycin, which are working on those motilin receptors in the GI tract to kind of do prokinetic actions. So that's better for someone who's having, say, like gastroparesis secondary to like diabetes. If they're having like a neuropathy from that and they weren't passing things along effectively, you could use a prokinetic agent like that to move things forward.
I think more my question is, from what I was studying and maybe not understanding, it seems as though both conditions, both diarrhea and constipation, we're looking to get water into the colon. Draw water into the colon.
Not necessarily, because with the diarrhea, typically you are more trying to either make what's there kind of better formed, or you are, say, giving something like an opiate receptor agonist, which will help kind of slow down GI motility, right? So something like the Imodiums, things like that, like the diphenoxylate, and what was the other one? On the tip of my tongue, but Yeah, low modal. Yeah.
Oh,
Yes.
So for like because in clinic we learned about patients that had hypersecretory, that no matter if they eat or not, like even if they're fasting, they still have diarrhea.
Mm-hmm.
So what would you give a person with hypersecretory diarrhea?
Hypersecretory, isn't that the ones
Yeah, it's more like an acid producing condition. I'm obviously not a GI practitioner, so I would probably say, what does their GI doc say? But I imagine they probably start with like a bulk forming laxative just to start out with, just to see if they can kind of help draw in whatever water is already there, the excess fluid, to try to help kind of form that. And then after that, it's going to be more of an issue of like, using like an opioid receptor agonist, something like the diphenoxylate that will help maybe slow things down. But I'd have to do more searching in the literature to find out what the most up-to-date recommendations are. But I imagine that's probably along those lines where you'd start. Okay, good. So I think we covered most of that stuff. Any questions on the GI? Yes.
For unspecified IBS, is that flipping back and forth between constipation and diarrhea?
Yeah, so it's kind of like they're just having kind of both ends of the spectrum there. May not be as extreme as one or the other, but kind of flipping back and forth.
In terms of antispasmodics, is that only for having big urine stools? Or like why would you use antispasmodics in IBS and acute?
Usually I see more antispasmodics being used for just the cramping issues that they're getting there to kind of help relax some of those muscles. That's where you see like a lot of the levsin or the hyoscyamine being used as an antimuscarinic to help kind of just slow down all that musculature just clamping down constantly. That's where I more see it being used. Yeah. Okie dokie. So just remember when you're looking at UC versus Crohn's disease, which medication are going to be effective for which in regards to enemas, suppositories. We kind of discussed that already, so just be aware of that. And then we mentioned the IBS, which medications are better for which ones, right? So something like lubiprostone would be better for IBS with constipation or diarrhea. Remember that drug? Is that Amitiza? That's for constipation, right? Because it opens up the chloride channels and helps kind of draw some of that fluid in, right? So just be aware of those, right? So if I were to say, patient comes in with IBS with diarrhea, which one of these would not be an effective therapy for them, right? So I might put like a bulk forming laxative. I might put diphenoxylate. I would put, say, bisacodyl, and then something else that's not the right answer, right? Then you say, okay, well, this one's a stimulant laxative. I would not use that for diarrhea, so that would be the right answer, right? Okay. Then looking at erectile dysfunction, so remember there are lots of drug causes. What are a common drug cause for erectile dysfunction? Or what are drugs that cause it? Yeah.
Beta blockers.
Beta blockers.
Calcium channel blockers.
Well, Viagra doesn't cause it. It is used to treat it, right? So yeah, so usually it's going to be antihypertensives that are the big ones here, right? So things that are affecting blood flow is going to be affecting that. So that's usually your most common causes. So we kind of need to go back to the med list beforehand to see, is there an easily identifiable reason why they're having this issue? Maybe they're on a, say, clonidine for blood pressure management. Maybe if I switch them over to an ACE inhibitor, they're not going to have this big an issue, right? So go back and look at the med list first before you start to add on new drugs to their regimen, right? How are these drugs working, like your phosphodiesterase inhibitors?
They're not letting
CGMP. Where do they do that? It's the end goal, right? So dilation is the end product. How do we get there? So remember, so we're inhibiting phosphodiesterase. Phosphodiesterase breaks down what? CGMP, right? So by inhibiting that, we have more CGMP, which is able to keep less calcium within the cell. So you have vasodilation that occurs, right? So it's very similar. It's going to be probably preferential on the arterial side, right? Yeah. So again, this is similar to how we saw their nitrates working. They're just working on donating the nitric oxide that stimulates the CGMP.
Probably a really stupid question. But like patients that have like when they're using like the injection stuff, let's say, or the pump, are they still able to reach climax?
I imagine they would. I'm not 100% sure.
You can't shoot if you're not pointing, right? So
But they're artificially pointing, so like, would they still be able to shoot?
I believe yes. I believe it's more due to the sensory stimulation. Now, if you had someone who had like quadriparesis or something and they didn't have that nerve reflex happening there, that might impair that. But I imagine, yes, they should still be able to. Yeah, good question. All right, so we mentioned that. We mentioned how we have our prostaglandins. How are those going to work? The alprostadil. Yeah, that's working on increasing cyclic AMP, right? So again, one is helping to prevent breakdown of cGMP. The other one's helping to stimulate cyclic AMP. So a little different mechanism there. So important drug interactions with phosphodiesterase inhibitors. Nitrates. Absolutely. Those are the most important ones because, again, if you're on a nitrate, you can't take these. If you're taking these, don't give them a nitrate. You can bottom out their blood pressure. Not good if they're having a heart attack, right?
There's one 3A4, by the way.
Mm-hmm. Yeah. So also be aware of any CYP interactions. Run your list beforehand. So mention contraindications, drug interactions, and then again, look at drug selection based on your patient. So obviously, if they need to have some sort of therapy and they can't take a phosphodiesterase inhibitor, say they're on a long-acting nitrate that you can get them off of, then maybe the alprostadil is going to be a better option for them. So just evaluate your patient, do it on a case-by-case basis. If it's something where the patient is say he knows very reliably, like, yes, this is when I'm going to need it. Maybe he doesn't need something that's going to last all weekend, right? Maybe he doesn't need like the tadalafil to do that. So keep in mind, to just talk to your patient and figure out what's best going to suit their needs. I remember I would have, when I was working at CVS as an intern, I would have a guy who came up every single Friday, or I guess it was every other Friday because it was payday, and his insurance didn't cover a lot of those back in the day. But man, he was dressed to the nines, ready to go out on a night on the town, buy one pill, and that was it, cash only. But that suited him. That was his deal. So, right. So just be aware of that. What other drug adverse reactions can you have from these drugs? The phosphodiesterase inhibitor specifically. Priapism is one thing we worry about. Actually, not super common as you might imagine. But so again, priapism being defined as what? Doesn't wait for 4 hours. Consult your right. So right. So that's the big thing. One of the big things you worry about. Specifically, what other side effects could I see? Would say something like sildenafil. Why blind vision?
Decreased blood flow to the
Good. PDE6, right? So PDE6 is in the eye, and so yep. So it affects the rods and cones. If you say decreased blood flow to the retinal nerve, that can cause blindness, right? Say which one caused more muscle or myalgias? PD11, which can be seen with tadalafil, right? Which is interesting. We actually we were doing a study on that one in kids with Duchenne's muscular dystrophy. We're actually seeing if by giving them that and inhibiting that phosphodiesterase, if we can increase their walk time. And unfortunately, ended up getting cut early because it was not showing any benefit. But sometimes you'll find other uses for these drugs other than what you would initially think.
Would you avoid those in patients on statin?
If they were, probably not necessarily, unless they were already having issues with myalgias with the statin, right? In which case I probably would have switched them over to something else that was not going to cause those issues. Yep. Okay. Then BPH, any drug causes you can think of that could do this?
shooting up, like steroids.
So yeah, so testosterone, right? So if you had any kind of like testosterone replacement, so if you had like Androgel or patches, or if you're giving exogenous steroids, certainly those could, would that more affect the constriction of the prostate or the size of it? The size, right? So hormones are affecting the size of it more so than the constriction. What could make it squeeze down more?
Smooth muscle.
No.
Just remember
So what type of antagonist are we going to give? Yeah, so adrenergic agonists, right? So something like pseudoephedrine, phenylpropanolone, all of those things could squeeze down on, and again, because think about the drugs we're giving to help prevent that squeeze, alpha-1 receptor antagonists, right? So by giving those drugs to prevent that squeeze, you can help to improve the symptoms, right? So think about that, and think about your patient. So if they had a really large, enlarged prostate, you might be thinking, hey, this is more of a testosterone issue. Maybe I can give them what type of drug?
5A reductase inhibitor.
Yeah, so you might consider a 5-alpha reductase inhibitor. Those are also going to be better for, say, someone who had, say, cardiovascular issues, right? You may not want to give them an alpha-1 antagonist. You kind of miss some of those issues with something like Flomax because it is so specific for that alpha-1A receptor that you don't see a lot of cardiovascular compromise with that one. Thought someone had a question. Yeah.
Did you? Yeah, you did. Okay. You did give examples.
Okay, cool. All right. Any questions on the BPH stuff? Okay, and then kind of similar stuff with urinary incontinence. So what could cause urinary incontinence? Age, gender, menopause for sure.
Sudden movements.
Like sneezing or something. Yep, ACE inhibitors, right? Because that's kind of an indirect kind of cause you wouldn't think of necessarily. Well, any other drug causes? What causes you to pee more? Diuretics, right? That could do it too, right? If you have the increased urge to go, you might have that pressure overcome and have incontinence there. So, so what type of drugs can we use to prevent this?
How much type?
Incontinence, did you say? Did you say for incontinence?
Yeah, for incontinence. So again, so you said it depends on which types. What types are there? Stress versus
overflow. What's the last one?
Urge.
Versus urge, kind of overflow. So what kind of drugs can we give for, say, like the overflow incontinence?
Anticholinergics.
Right. So what do anticholinergics do in that case?
They increase the bladder storage.
Right. So basically, they kind of relax those detrusor muscles. Right. Because if you think about, we talked about the anticholinergic side effects already. Say they dry you up. Right. They also cause urinary retention. So if I can give a drug like that, it helps to relax those detrusor muscles and help give you more storage, right? So that's one of the big things for that. So know your drugs for that, like ditropan, oxybutynin, tolterodine, sulfennis, and all those drugs on that list.
Sorry, sidetrack. But for the alpha reductase inhibitors using BPH, are they used for other indications as well? And why? Because you put this as category X. But if it's used in BPH.
Exactly. Yeah. Exactly. They don't they always recommend women especially of childbearing age have gloves on when they're handling the drug. Especially if they are compounding it. Like say you needed to put it into a suspension. Make sure you're doing it with a mask and under a hood, so that way it can vent out the particles and stuff like that. So yeah, so they take that one pretty seriously because anytime you're monkeying with hormones in a pregnant person, it can be deleterious to the fetus. Good question though. Yeah, that wouldn't make sense. Why would you give that to a pregnant lady? But you wouldn't really. You just don't want them handling it. All right. Okay, good. So any questions on that? Fantastic. Okay, so we'll talk about. You guys want to take a break this time, or do you just want to power through? Just power through. Okay, I can do that. All right. If you need to go to the bathroom, you can get up, but it'll be recorded. So remember, with acute kidney injury, we have three main types. So pre-renal, meaning that we're having an issue with what? So it could be hypovolemia, but essentially we don't have enough blood getting to the kidneys, right? Not enough perfusion, okay? So imagine what are some drugs that could cause that? ACE inhibitors, right? Because remember, if we are, is that working on the afferent or the efferent arterial? Or it's on the efferent arterial, right? Because Ang2 is vasoconstrictive, right? So we're kind of constricting the efferent arteriole. So if I open that up with an ACE inhibitor, all of a sudden I lose that backflow pressure, right? So I'm not having enough blood getting actually filtered into the kidneys. On the other side, on the afferent side, what could affect that? Yeah, NSAIDs are the big ones, right? Because you're inhibiting prostaglandins. Prostaglandins are vasodilatory, right? So then you have a squeezing of that afferent arteriole and less blood flow hitting there, right? What other drugs could potentially cause pre-renal acute kidney injury?
Diuretics.
Diuretics are a big one, right? Because it causes hypovolemia, right? You get rid of fluids, you may not have as much to filter. Because again, the body's always going to preferentially perfuse the heart and the brain, and the kidneys kind of get short shrift there. Good. So intrinsic structural kidney damage is happening here. What type of drugs can cause intrinsic kidney injury? So nephrotoxins like vancomycin, aminoglycosides, IV contrast, cisplatin. Yeah, those are other big ones. Right, so keep in mind that there's, there might be a question on the exam that might be asking, a patient is in this kind of condition, you give them this drug, and they have acute kidney injury, and you need to predict what type of injury it actually is. So be able to differentiate that, right? So again, if the drug is causing them to have decreased perfusion to the kidneys, Then you think pre-renal, right? If it's doing something where it's actually causing direct damage to the kidneys, intrinsic. And then what would be something that could cause obstructive or post-renal kidney injury?
BPH.
So BPH could be one, but what kind of type of drugs could do it?
Calcium supplements.
Why calcium supplements?
Kidney stone.
Good. So kidney stone. What else? So similar to have calcium precipitating out in the tubules, right? And that could be anywhere within in the urinary tract. What other drugs can crystallize out?
Oh,
Phosgornet, which is an antiviral. So then other antivirals like acyclovir is going to be a big one, right? Acyclovir. So again, anytime you're giving somebody acyclovir, they need to drink a lot of water, right? Because you don't want that drug precipitating out, causing this obstruction. Any other type of drugs? Maybe one that we use to treat, say, Crohn's disease. Nope. It's an immunosuppressive drug. Nope, so not the MADs. The MADs are actually, those are just proteins. You don't have to really worry about them precipitating out. This one's going to be methotrexate, right? So methotrexate is one that you need to, sometimes when we're giving high-dose methotrexate to patients for chemo, we're actually giving them sodium bicarbonate along with that in their IV fluids. That way you make sure you keep the urine alkalized. By keeping the pH up, you prevent the drug from precipitating out, right? So hydration is a big name of the game for preventing post-renal kidney injury, right? One other big one for intrinsic that we didn't mention is going to be ambisome or that amphotericin B. That one's really, really nasty. So if you need that one for like a really invasive fungal infection, ambisome or amphotericin B is one you want to be aware of as causing kidney injury. Now remember, ambisome is that one that has like that lipid bilayer that actually helps to prevent some of that kidney injury. But if you use just a straight drug, they also call it amphotericin B because it is so bad for the kidneys, right? What are some ways that can help prevent acute kidney injury? So when might I use Mucomist or N-acetylcysteine? Good. So I might use Mucomist or N-acetylcysteine for IV contrast. You know, some people think maybe vitamin C might be able to help because they work as antioxidants, right? So kind of plus minus on you know, those working. What are like kind of concrete ways we can prevent acute kidney injury? Tank them up, right? So give them lots of fluids. Good. So that's a good one, right? Avoid nephrotoxins, right? So if we can avoid using, you know, amikacin, if we can use, say, something else that might still treat the infection, go with that, right? What else can we do? You may, maybe. That's again one of the kind of plus minus ones, right? As far as, but you know, avoiding, you know, nephrotoxins like, you know, aminoglycosides and amphotericin B are big ones. What was the other? Someone else said? Yeah, so the aminoglycosides. And so in the case of another good example would be like someone who's going in for contrast. There's a certain diabetic drug you don't want them to be on if they have poor. Yeah, so that's another big thing you screen for is make sure that they have poor kidneys and their creatinine's already above 1.5 or 1.4 depending on the gender. They will make sure that you're not taking metformin, right? Because that can help build up if you have acute kidney injury and cause lactic acidosis. That can be really bad. What could I do with my aminoglycosides to make them less likely to cause acute kidney injury? Yeah, so once daily dosing can be a big one. And also doing that pharmacokinetic monitoring, we're actually basing your dosing on the levels, right? So either changing how often you're giving it or how much you're giving it to make sure you're not accumulating the drug, causing injury there, right? Good. Just remember, GFR and serum creatinine are always going to lag by 1 to 2 days. What are some other cases where serum creatinine might be misrepresentative of the patient you're dealing with? Good. So amputations that will falsely increase or decrease your GFR? I'll say increase it, right? Because it looks like our denominator is smaller, our creatinine is smaller than it should be, right? What else could do that?
Smaller people. Smaller
people, potentially, especially like little old ladies. Right, they try to take that into account if you look at like your Cockcroft-Gault equation, but remember that's not going to be good for every single patient, right? So if I use Cockcroft-Gault for, you know, say a small child, that's going to misrepresent what their actual creatinine clearance is. If I use it for someone who's 98 years old, that's also going to misrepresent because again we know they have decreased muscle mass compared to their body weight. So be aware of that. Be aware that you're accounting for your type of patient when you do the calculation. So for instance, they might use an MD-RD equation for a really old patient. We have the what was the equation we used for kids? The Schwartz equation is the one we use for children. So just be aware that there's different formulas out there for different patients.
Do you want us to have that formula memorized?
No. Just be aware that it will take, like Cochran will take into account things like age, weight, serum creatinine when calculating that. So you're already taking that into account, but be aware that how patients may differ from that significantly can affect your GFR, right? So for instance, in nowadays when we have such issues with obesity, we have patients who are 400, 500, 600 pounds with somewhat regularity, right? And so, as you start to increase weight that much, how much of that is going to be muscle mass? Not a ton, unless you're like, the mountain from Game of Thrones or something, right? So most of the time you're not going to have strongmen who are coming into the ICU for respiratory failure, and so in those cases you have to do things like adjust their body weight. So there's calculations for that to try to get them a little bit closer to what their actual muscle mass increase is in trying to do that. So just be aware there's changes out there, and that one size fits all in calculating serum creatinine or calculating creatinine clearance is not going to be perfect, right? Okay. We already mentioned things that can lead to drug-induced kidney injury. So again, here's just a little bit more big list here just to mention this. So be aware that you can have pre-renal and post-renal issues that feed into an intrinsic damage that occurs, right? So for instance, if I have hypoperfusion of the kidneys for a long enough period of time, that leads into ischemic insult to the actual tissue of the kidneys, right? So you can have things evolve from one into the other. So for instance, if someone's really dehydrated, if I can get them early enough and give them lots of IV fluids, I may not have any intrinsic damage done. So it's really kind of a transient pre-renal kidney injury. Similarly, on the post-renal side, if I can get that precipitation cleared up, say by increasing the pH of the kidneys or getting them better hydrated, that can prevent the ischemic injury from occurring. So keep in mind, it's an evolving process. One may lead into the other. Okay, so another big issue you run into with those patients with chronic kidney disease is going to be anemia, right? So anytime you're giving an erythropoietin stimulating agent, you always want to give iron. Always got to give the iron, right? Always give iron. Could be oral. It's fine for most people. Some people are going to need IV iron. So be aware of the differences there. Now, what is the problem? Say, when should I stop giving these ESAs?
Above 10, but you don't want to go above 13.
Exactly. So above 10, you probably don't need to give anymore. Why is that? Yeah, you were about thrombosis, because essentially, if you imagine, if you keep increasing the hemoglobin content of the blood, eventually it's going to get more viscous and kind of start to sludge a little bit. So that's where you start to worry about thrombosis occurring. So that's where they're finding increased risk, MI, stroke, venous thromboembolism, all those things. So that's why you never want to go above 13. Once they get kind of above 10, you kind of leave them alone, right? Just keep supplementing their iron, because again, they're going to have poor absorption of that anyway. So that's a big thing to watch for. Very expensive agents, but they can be they can do wonders for a patient's quality of life, because if you have not enough hemoglobin, it's kind of pretty crummy existence there. You get tired from everything, basically. Maybe that's why I'm so tired today. Definitely not my 6-month-old. Okay. Looking at the electrolyte management, so again, keep in mind you can see issues of hypernatremia, fluid retention is pretty common, how we can treat those things. If they're edematous, you can always give a loop diuretic to help get rid of some of that fluid, but keep in mind that's not going to really provide any other therapeutic benefit than just fluid status. Again, there's lots of different indications for renal replacement therapy. I'm not going to quiz you on that, but just be aware that that it's good for getting rid of a lot of those excess electrolytes. That can fix hyperkalemia. It can fix issues with sodium and things like that pretty effectively. Except for phosphorus and magnesium, those are still going to be difficult to manage. What are some things we can do to deal with phosphorus? What with calcium? So you want to give them more calcium and get all these ossifications everywhere or calcification? Yeah. You want to bind it? Okay. How can we do that? Yeah, so aluminum hydroxide you could potentially give. What are some issues with giving aluminum in those? Yeah, so over time they've actually seen that patients could accumulate aluminum because they can't excrete it from the kidneys and had some CNS effects. So you're right, calcium you can give in the GI tract, right? So that's where you can give calcium carbonate. There's calcium acetate. There's different products there. There's also like your lanthanum and sevelamer. Typically you start with the calcium products, so those are cheaper. And then if you're not able to get the phosphorus in check, then you start to kind of scale up and use some of those other agents. Good. Again, remember patients on RRT can become hypocalcemic. Why is that? Right, because you have to add that citrate in order to keep the blood from clotting off in the circuit, right? Because that's one thing you don't want to have happen when you're taking blood out of the patient into this machine. All that plastic and things like that and are able to activate the clotting cascade. And so by binding up calcium, you prevent that from occurring. So you have to give them calcium back into the blood, otherwise they're going to become hypocalcemic. Okay. So again, just be aware of this kind of cyclical pathway here, knowing what's going to be feeding into one another, knowing that by having poor kidney function, I'm going to have higher phosphate levels, which leads me to have lower calcium levels, which leads me to have higher PTH levels, which is going to cycle back around to causing more bone damage. It's going to cause more calcifications to occur, going to cause further kidney injury. So just know it's a kind of a vicious cycle that's happening here. You had a question?
Yeah, the citrate anticoagulant, is that only used in the non-peritoneal dialysis?
Yes, yeah. So that's frequently used when you actually have like the dialysis machine. Usually with the peritoneal dialysis, at least from what I've seen, has been done. Usually it's more like kind of gravity flow, where you basically, because you're not really taking the blood out in that case, really, because you're putting fluid into the peritoneal space, and then you're letting it sit there for a while and letting things kind of equilibrate, especially a lot of waste products and things like that, and you just take it out. Since you're making pee in the peritoneal space, essentially. So don't have to worry about that there. Cool. Okay, so again, just some of your phosphate binders you can use. Again, you probably save aluminum for kind of later cases if you're still not able to get there. What's the biggest way you can help manage their phosphorus? Diet. You had a question?
The landfill accumulation, is it causing any like side effects or just accumulation into like precipitation?
I've not really seen any issues with lanthanum accumulation. There might be some studies out there that say otherwise, but it's not really going to be as big an issue as their phosphorus levels, right? So just be aware of that. Okay. So when would I dose my phosphate binders? Yeah, when would I give it?
At night.
At nighttime? Why? Hmm? Yeah, before meals, right? Because that's when I'm going to be ingesting most of my phosphates, so that's when I want to bind them up, right? Okay. Okay, so again, looking at sodium and water homeostasis, this is probably the place where most people are going to have questions, so that's why I included most of these slides here, because I saw a lot of scared looks on people's faces. Yep. Okay. Right, so basically, what is this slide telling us?
The different osmolarities of each one.
Right, so I have different osmolarities of the different fluids. And then what about this whole ECF, ICF stuff? Yeah, where's the fluid going to go, right? So when I put it into the patient, where is it going to be at the end of it, right? So say, for instance, I have a patient who's septic. I know the third spacing because they have really leaky capillaries. So all their fluid is going into the interstitial space. Intravascularly, I know they're depleted because their blood pressure is low. What would I want to give to them?
High concentration salt.
You want to give high concentration salt? So stay away from high concentration salt. So anything greater than 0.9, unless. So again, because think about it, like if I'm giving you for the same volume or for the same amount of sodium, if I use say 3% versus 0.9%, which one has the higher volume of fluid? 0.9%, right? So because it's less concentrated. Those patients, they don't have enough volume in their vasculature already, so I want to give them fluid. And I want that fluid to stay there. So that's why I give the 0.9%, because that way I can kind of tank up the intravascular space.
But won't it make the water that's in the interstitial fluid go back into, as the concentration's higher in at that
It's
point?
going to equilibrate. So think about, because again, your salt content within the blood itself is going to stay somewhat stable there. So even though you're leaking fluid into the interstitial space, like you're still going to maintain a somewhat constant sodium level, right? So it still may be in the normal range, say 140 milliequivalents per liter. When I give normal saline into that, you're not going to see a big shift, and most of that fluid is going to stay right there in the intravascular space.
So we're not trying to pull water from the interstitial space.
Not really, no.
Just fill up.
Yeah. So a lot of those patients, they could have issues where they're having pulmonary edema developing. You can have issues where they have, ascites and other pitting edema and things like that. most of the time you're trying to get their cardiovascular status fixed first, right? Because that's why we know they're edematous to begin with. If you need to get rid of some of that fluid, that's where you can use things like loop diuretics, right? But again, if you have a patient who's, say, coming in from the nursing home, I know they're septic, I need to get their inflammation fixed first, so I'm going to give them antibiotics, maybe steroids if they need it, and then that's going to help the vasculature become less leaky. Those gaps and all the epithelial cells are going to start to close up, and then I know the volume's going to stay there even better then.
Can you say that the fluid goes to the intracellular space? Do you mean intracellular? Are you saying like extracellular?
Intracellular is the cell.
Yeah, within the actual cell itself.
Interstitium would be
Interstitial.
like.
So when I'm saying interstitium, I'm just saying outside of the actual blood vessels and into the surrounding space.
So that's
Yeah, so majority that's going to be intracellular fluid, right?
extra.
Because again, the volume is going to start to go into the cells, right? So if I have fluid leaking out of the blood vessels, right, that's going into the interstitial space, a lot of that's going to end up going into those cells. So think about that intracellular fluid from that regard, right? Where we're talking mostly about extracellular fluid, majority of it's going to be in the blood vessels themselves. Okay, so think about it like that. That's where, right. So that's where it keeps that normal balance. So if I give more concentrated things, so something like 3% saline, it's going to draw water out of the intracellular space into the extracellular fluid. So for instance, if I have someone who's having, say, cerebral edema secondary to head trauma, I want to give them hypertonic saline because giving that high solute and the hypertonicity within the blood now is going to draw fluid out of the brain, which has a lower solute concentration. Because water wants to go from an area of high concentration to low concentration.
This is where my question comes in. So
Yep.
Can I ask it again?
Yep.
Okay, so you said,
I changed my mind. Never mind.
I don't know what slide number it is, but it's one of the hyponatremia ones. It
Mhm.
says euvolemic hypotonic hyponatremia.
Right.
Normal amount of ECF-NA increases total TVW and ECF.
Mm-hmm.
So why is ECF being increased if it's hypotonic?
So
Wouldn't that be the opposite?
what's the most common cause of euvolemic hyponatremia?
I don't know.
Dehydrated?
Because they're euvolemic.
Oh, you.
Euvolemic hyponatremia. SIADH, that's the biggest cause, right? So SIADH is a big one. So if you have a patient whose fluid status looks pretty normal, they look euvolemic, so they don't appear to be edematous, they don't appear to be dehydrated, they appear pretty normal. That's because the body's kind of compensated to having that increase in antidiuretic hormone, right? So even though they may be still urinating, their body's starting to equilibrate to that, where now they have a higher water for that same kind of amount of sodium, right? So even though they don't appear to be edematous, they're still kind of holding on to more water than they are sodium at that point, and so they become hyponatremic. So, and because they're hyponatremic, they're also hypotonic.
But it's hypotonic. Doesn't that mean that
That just means you're diluting out the sodium that's there.
ECF?
It's all about, so there's an equilibrium at some point, right? So it eventually, as the solute in the blood starts to get thinned out, say by holding on to more water, that's going to get transmitted across the tissues too. So eventually that sodium is going to maintain a homeostasis to where the water flow is going to be kind of maintained between the two.
So then how do we really understand what's happening? Because it says it's hypotonic, but
Mhm.
yet that's going on. Do you get what I'm asking?
Yeah, so that's why, so when you're assessing a patient like that, you're looking at things like their serum osmolarity, right, which should be low for those patients, right, because they're hypotonic, and you're looking at their sodium, which is going to be low because they're hyponatremic, but you're also looking at their volume status, right? And so then you can look at things like the urinalysis as well, because that's also going to give you some hints there, right? So if I'm giving if I have SIADH, so I have too much antidiuretic hormone around, right? So that means I am kind of concentrating my urine too much.
Compensating for it.
Exactly. So I'm concentrating too much, and so I can see maybe higher osmolarity in the urinalysis, right? So taking all those facts into account, you can kind of come up with an idea of what your patient is experiencing. Right? Especially if you have like a smoking gun, like I know they have a particular drug, or they've had a head injury and they develop this, right?
Sorry, maybe we're kind of going on that. Can you give us an example, maybe, of when we're determining if it's hypo,
Yeah, exactly. So how would you assess a patient's volume status? Okay, so you can look at urine output. Blood pressure is going to be a good one, right? So if blood pressure is low, and say like skin turgor is skin's not very elastic, and they have what about with like a pediatric patient? What might you notice? Yeah, sunken fontanelle. Yeah, sunken eyes. All those things let you know that they look volume depleted, like they look hypovolemic, right? So that's kind of your first step. Euvolemic patients, would look pretty normal, and then a hypervolemic patient would be what? Be edematous, they'd have ascites, pitting edema, all those things, right? So you make your assessment of the patient based on your physical exam, right? And then at that point, then you're going to start to look at your laboratory test, okay? So again, you would do, say, a basic metabolic panel. You'd also measure something like a serum osmolarity, and then you could say you do a urinalysis, okay? So your BMP comes back, and say your sodium is 120. What does that tell you? They're hyponatremic, right? Okay, so now I know they're hyponatremic, so now I need to figure out why, right? So then I go ahead and get the serum osmolarity, and it comes back and say it's like 270. Does that sound low, high? Oh, you haven't gone over the things labs? Okay. Okay.
She just gives us normal lab values.
I don't even remember these.
Okay, so it's good to have, so especially for rotations, it's good to have at least some idea of the normals when you're out there. So you can look at a set of labs and you can be like, okay, that looks wildly abnormal, or that looks about normal. So so say for instance, and I'm not going to make you assess lab values on the test. I will say they're hyponatremic, they have their euvolemic, whatever happens, I'll give you that. So essentially, if you're looking at a patient and say 135 to 145 is considered normal serum sodiums, right? So if I said 120, that means they're pretty low, right? That's usually where patients start to become more symptomatic. Usual serum osmolarity is around say 280 to 300 ish. So if they came back, say 260 or 270, that tells me they're low, right? So I know they're isotonic, or so they're hypotonic, right? So they're too dilute, essentially. So I know they're holding on to too much water, and that frequently tells me it's something like there's too much ADH around, right? Because the other thing that ADH does, rather than just hold on to water within the kidneys, it also stimulates your thirst, right? So I never forget, working in the surgical ICU, you'd have a lot of trauma patients where we would be managing them after their initial surgeries and whatnot, and the head injury patients were very fascinating to work with, because one, they'd have all these kind of crazy mood changes where you'd have a really nice sweet old grandma who would become like suddenly very, very belligerent afterwards, and then you'd have people who were having this SIADH, and the thirst that they had was so great that they would cheat, lie, and steal to get some Gatorade, right? Like they wanted something to drink so bad. And one of the big therapies for SIADH is water restriction, right? So we don't want to give them water. So they would have their family members sneak down to the cafeteria to grab stuff. They would be sneaking it from other patients' rooms. They would do anything they could to get some water, right? Because that thirst was so great, and we couldn't really do anything for them otherwise. And we'll talk about some of the medications you can use for that. So again, assessing them, figuring out they're hypotonic. They're usually, if they're hyponatremia, they're most often going to be hypotonic, unless they're just totally volume depleted, in which case we'll talk about the different therapies for that. But that's essentially how you're making your assessments. Your analysis can also help as well, especially if you're looking at something like diabetes insipidus, where you're having like no concentrating going on. You have really like kind of hypotonic urine that comes up, or if you have way too concentrated urine. All those things used in an amalgamation can tell you what's going on with your patient.
So I think my problem is, so hyponatremia is fluid excess.
Hyponatremia is having a serum sodium level that's less than 135 milliequivalents per liter. Yeah. So imagine, say I was having a radio contest, and I was making you drink a ton of water, and whoever could hold their urine the longest got a wee. That person did die, right? Because they ended up drinking so much water. What do you think the osmolarity of their blood, did it go up or down? Went down, right? Because I'm diluting the blood, right? I'm having so much water adding into the bloodstream that the sodium level starts to go down as well, because I'm not adding any sodium. They're not drinking Pedialyte, they're drinking just straight water. So sodium levels going down, so they're hypotonic, they're hyponatremic, and then when you get low enough, you start to see the CNS effects. So she ended up seizing and dying due to that.
So based on all of that, so if you're diluting it so much with water, you become hyponatremia. How do you have hypovolemic hyponatremia?
So that can be an issue where you have losses due to, you're not having any replacement. So say for instance I have really significant vomiting, diarrhea, I'm having a lot of diuretic abuse, all those things are making me lose water and sodium at the same time. So I'm volume depleted because I'm getting rid of all that volume, but then I've also lost a lot of salt as well.
so I get what you're saying, but I think what I'm struggling with is what the heck is hypertonic and hypotonic really mean?
Gotcha. So hypertonic simply means you have too many solutes in the blood, right? So it basically means the blood's too concentrated.
Okay.
Hypotonic means the blood is less concentrated or more dilute.
Okay.
Right? So if I said a normal serum osmolarity, say let's say 300 milliosmoles per liter, if I were to add, say, more water to that, just straight water, what is that going to do to my osmolarity? It should make me more hypotonic and should dilute that out, and the osmolarity should go down.
So how does that relate to this whole ICF, ECF, and where it's going thing?
So this is just talking, this slide here is just talking about when I give fluid, where's it going to end up? This is separate from managing a patient with hypovolemic, hyponatremia, or based on tonicity. This is just trying to say that this is why we give the fluids that we give to a patient, right? Okay. So say, for instance, I were to have a patient who was, say, hypovolemic, hyponatremic. What type of fluids am I going to give to them? Would I give them D5? It's all free water, right? So that's not really going to replace any of the volume there, because most of it's going to end up in the intracellular space. I wanted to stay in that intravascular space because I know they're volume depleted, right? So I would use something with more sodium in it.
So hypertonic? So
there's a distinction there. So again, if someone is volume depleted, I want to give them enough fluid. So I'd end up using isotonic fluid, right? Because at that point, if they're hyponatremic, say if their serum sodium is 125, and I'm giving them normal saline, how much sodium is there in normal saline? 154 milliequivalents per liter. That's already hypertonic to what they are, right? So by giving them normal saline, that's starting to help equilibrate and helping to correct their tonicity and also their volume status.
When would you use 3 then?
So you would use the 3 if they are having severe symptoms of hyponatremia. So if they come in and they are acutely seizing, that's usually a good case to do it. So hyponatremic seizures are a good case. If you are having a patient who has say a hypervolemic status and you don't want to give them as much fluid, that's when you can use concentrated sodium, right?
So if they're hypervolemic.
If they're hypervolemic and they have too much fluid on board, I don't want to give them much of NS. So if you think back to that example in the slide where we were talking about the lady who came in with hyponatremia, right? And I said, how much volume would it take to correct her if I gave her normal saline? And how much volume would it take to correct her if I gave her 3% saline, right? So the volume difference was pretty great there. I can give a very small amount, let's say a little less than a liter of 3% saline versus giving something like 12 liters or whatever happened to be on the slide of normal saline. So that volume difference can make it can be big for some patients depending on what their volume status is to begin with, based on their renal function, pulmonary function, things like that.
I have a question about that question.
Okay. You don't have to calculate that on the test. Those are just for illustrative purposes.
That equation?
Yes.
We do or don't?
You do not need to calculate that.
I was gonna ask like,
Okay. Everyone with me so far? Clear as mud. Yes, it's more concentrated, right? So if you look at it, there's 513 milliequivalents of sodium per every liter versus having just 154, right? So it's a lot more concentrated. You also run the risk of changing some of the serum sodium too quickly when you give more concentrated sodium, right? Right, so how much do I want to correct in a 24-hour period? Right, no more than 12, because if I do more than 12, what happens? Not cerebral edema necessary, but what is the specific?
Oh,
Central pontine demyelination. That is the thing you will get sued over, and you will lose a lot of money to if you do that, because that is a, huh? If it doesn't kill them, it is, yeah. It's stripping the myelin off of your neurons. Like, yeah, that stuff doesn't come back. So it's a big deal, right? So that's why, you know, if you have patients that get corrected too quickly, like that's huge medical error, huge, you know, sentinel event that can occur. So you got to be really, really careful with those patients. So by giving something like normal saline, I'm less likely to screw it up because it's going to take a whole lot more volume to change that serum sodium by that much rather than just giving concentrated saline.
So you said we don't have to do calculations. So we have questions that we have to decide between normal versus 3%.
Yeah, so I would give you a question and say like, okay, what would be better for this patient? You know, say they are they're hypervolemic, they have ascites, and their serum sodium is 125, or say, I'm telling you they're hyponatremic. What would be a better option for them, right? You just say, oh, it's a more concentrated form because they already have too much volume on board, right? Or if I were to say they're hypovolemic and they're hyponatremic, what would be a good option for them? And they're just, you know, they're having some.
How mean,
they're not very severe. Say they're just having a little bit of lightheadedness or something, a little bit of confusion. Normal saline is going to be a lot better for them, right? So usually err on the side of using normal saline because you can kill someone with a 3%, right?
So I'm sorry, could you repeat that? You say in terms of hypervolemic, you do 3%? Hypovolemic, you would do 11%.
Yeah, so again, if they were, if I need to correct the sodium and I want to use less volume because they're already volume overloaded. So imagine you had someone who had bad CHF, bad liver disease, and they can't process that fluid, right? So they've got ascites, they got pulmonary edema. You may want to correct with something a more concentrated form like 3%, right? Because it's less volume I have to give them.
And would you also give a
Potentially. Sometimes you will see that where you give a loop diuretic along with a concentrated saline. That is rare because, again, they're kind of fighting each other at that point, right? Because in your preference, you're trying to get rid of more of that fluid volume than you are the sodium, which you're depleting with the loop anyway.
If you do give that loop, is that going to affect your ability to not go over the 12?
You're still playing with that initial 12. So if they come in and their serum sodium is 120, I'm not going to deviate that. I'm just going to say at the end of 24 hours, they should be around 132, right? At the end of that 24-hour period. Right, and so the other thing you have to think about, and I won't get too deep on this on the test, but there's cerebral adaptation that happens, right? Because your body likes homeostasis. So if I went a long period of time, say I developed SIDH and I went a long period of time with that being hyponatremic, the brain's going to start to equilibrate to that, and the brain becomes hyponatremic as well, right? Because things, it takes longer for things to cross the blood-brain barrier and equilibrate. So if I correct that really quickly with someone who's already adapted to that, that's where you're much more likely to see the central pontine myelinolysis or the demyelination syndrome, right? So a good example of that was when I was on rotations and I was in the ICU. We had a lady who was probably, say, 48, super out of shape, and she decided to go to a boot camp, right? And it was July in Florida. It was a bad scene, right? So of course she ends up getting very, very dehydrated, just sucks in a ton of water. She becomes very hyponatremic, right? So she was probably a little bit more of a little bit of hypovolemic, maybe euvolemic hyponatremia at that point. And so no one was taking into account the fact that she got several liters of NS bolus down in the ED. No one took into account, say the fluid rate of the saline that she was on up in the ICU. So the next thing you know, it would have been 6 hours and she'd already been corrected that 12 milliequivalents per liter, right? And so the nephrologist comes in, he's furious, and he's like, you can kill this patient, blah, blah, blah. But she had been hyponatremic for a short period of time, so she could tolerate that change much better than someone who had had that for several days and already equilibrated, right?
Now, how would you treat that? I mean, they just give her diuretics to...
Then you just leave it alone. Then you're just going to wait to see what her symptomatology is. You just see when her serum sodium kind of starts balancing out too. So usually you're doing serial basic metabolic panels as time goes on in order to interpret that. Yeah.
You don't restrict sodium though, right?
I mean, those type of patients, I mean, she was, intubated in the ICU. She didn't, we weren't giving like feeds at that point. So anything we were giving her would be through our IV fluids. Yeah. So then you could even, say once you get to a point where like, okay, I feel comfortable about this patient, then maybe switch over to, say half normal saline, right? So that way you're not going to raise her level up any higher than that. Okay. So I'll have a couple more slides on that. So just be aware again where fluid's going to go. Keep in mind this idea of free water. The more free water I'm giving, the more of it's going to end up in that interstitium and not necessarily in the intravascular space. So if you have a dehydrated patient, you don't want to give them D5 because not very much of it's going to stick around in the blood vessels. Any question?
Yeah, no, you said that we aren't going to have to calculate, but do you want us to know the concept of the difference percentage?
Don't memorize the percentages, just have an idea of that concept. If I have less sodium in that fluid, more of it's going to go into that interstitial space, right?
You wouldn't have as like a multiple choice of different percentages and you have to
No, I wouldn't make you say, like, okay, would you give this patient half normal or normal saline? Like, I'm not going to be super mean like that. I don't think, I might have to look at the test just to be sure, but I don't think I was that mean. I looked at it before I came in today, so. But again, remember this free water thing, especially with the 3% normals NaCl. Notice how it has that negative number there, right? So it's drawing stuff in from the intracellular fluid, drawing it from the interstitial space into the bloodstream. So that's why it can work for things like cerebral edema. Okay. So again, we kind of have been talking about this, you know, basically ad nauseum at this point. Essentially, though, again, looking at your, sorry if I can get my mouse to work. Again, so you're going to be looking at the serum osmolarity first to see kind of where they're at. Again, if the main thing we're going to be focusing on in regards to this is mainly going to be in this hypotonic hyponatremia, right? So don't get so hung up on the osmolarity anyway, because usually if you have a hypertonic hyponatremia, this is very frequently due to hyperglycemia. That's a hyperosmotic, it's HHS they get, where basically it's not DKA, but it's for type 2 diabetics to get like, you know, their blood sugar of like, you know, 1,000 or something. There's a couple of different abbreviations for it, but it's like the hyperosmolar, non-ketotic, hyperglycemia, whatever it happens to be. So anywho, so you know you're not going to see that very frequently, but just know that by having more glucose in the bloodstream, that's helping to dilute out your serum sodium. So that's why it appears they have hyponatremia, but it's false, right? So that's why you can say that every 100 of blood glucose you go up, you can account for your sodium, and so you can actually do a correction there to say, well, they're probably closer to a normal sodium than what this is actually showing us, right? So again, focusing on the hypotonic hyponatremia, right? Then you're just figuring out what their volume status is, and then based on that, you can look at things like the urine osmolarity, and that'll give you some hints as to what's going on, right? So again, we'll go into the slides on this. So if you had a euvolemic hypotonic hyponatremia, so again, focus on the euvolemic hyponatremia being the key things there. Most often, that's going to be things like drug-induced SIADH, right? That syndrome of inappropriate antidiuretic hormone. So your brain's kicking out too much ADH, you're holding on to too much water, and you're wanting to drink more as well. So things can either sensitize the kidneys to ADH, or things can release more ADH. I'm not going to get super deep into the difference between those, but just realize that when we talk about something like some of our drugs that work for, say, diabetes insipidus, they are going to be working kind of through on the effects on the kidney, right, or working on those receptors there. Right, so especially when we're giving something like DDAVP for diabetes insipidus, that's working specifically on those receptors in the kidney to help reverse some of that. Again, correction, you don't want to do that too quickly. This osmotic demyelination syndrome or central pontine myelinolysis, either one, this is going to be the same name for, or different names for the same thing there. But we talked about that. More adaptation that's happening in the brain, the worse it's going to be. And don't go more than 12 milliequivalents per liter in 24 hours. Okay, so again, I'm not going to make you do this equation here, but just be aware that, you know, by giving different concentrations of sodium in that IV fluid, you're going to need different amounts of volume, right? So again, if they're volume depleted, it's okay to use normal saline to raise them back up, because chances are that 154 milliequivalents per liter sodium in the normal saline is already higher than what they have to begin with, so that's okay. So, again, for non-emergent hypovolemic hyponatremia, again, using normal saline, 3%, you just had that risk of overcorrecting too quickly. If they're seizing, or they're very severely symptomatic, then you can use 3%. And then normally what we end up doing is we'll do a certain volume bolus to those patients until they stop seizing, and then we redo their sodium and kind of see where they're at, and then we kind of subtract whatever we already corrected from their 12, and then we correct the rest of that throughout the next 24 hours. Again, it helps us to replenish the volume and the sodium at that point. For the management of SIADH, the big thing to do is to either restrict the water and hopefully correct the underlying cause. Sometimes you can't do that, especially if it's like a brain tumor or if it's a head injury or something like that. If you can't restrict the water intake, you can sometimes give them extra sodium in the form of sodium tablets, but what does that do to their thirst? Just makes it even worse, right? So again, it's not super fun for your patient. Sometimes you can give a loop diuretic to help manage that volume, though, again, to try to get rid of some of the extra water. Ideally, though, you can do drugs that would inhibit the activity of AVP or ADH at the site of the kidney. So this is where something like demeclocycline would be good. What type of patients would this not be good in? Pregnant. Kids under 8. You don't want to use it for them because the same thing would happen as like tetracycline. So again, that's going to be useful to help antagonize those effects. And we also had those baptans that are working against the V2 receptor. They're blocking that, so preventing the excess ADH your brain is secreting and prevent that from working there. So basically, we're reversing the effects of that ADH.
Because these people are so thirsty, before they come in, if they drink too much, do they become hypervolemic?
Potentially, if they drink a lot, but if they have good kidneys, sometimes you'll end up seeing them being able to pee off some of that. Yeah, it just depends, because again, they'll depends on kind of when you got to them. So earlier on, they may be a little bit more hypervolemic, but as they've had time to adapt, they might become more euvolemic, right? But in general, by the time you get to them, they'll probably be euvolemic. And then for hypervolemic hyponatremia, you want to make sure you're keeping that water balance negative, so you're actually losing more water than what you're holding on to. So again, hopefully you can correct the underlying cause, and then you can limit the fluid intake. Oftentimes you'll see these patients have issues with their contractility, or they have issues just managing the fluid themselves, usually due to their cardiovascular status. So again, if you can work on things like getting their heart pumping better, you're getting their, you can't really do anything with the liver, but try to help increase that cardiovascular status, so that way they can get rid of the fluid a little bit better. Okay. So a student question I had in a year past, they were asking, is normal saline going to be the best fluid replacement for a patient in shock? Or should they use normal 3% saline work better, or just as well with 100% of fluid in the ECF to replenish volume in the intravascular space? Kind of already alluded to this. Again, if they're very dehydrated, they're in cardiovascular shock, normal saline is the best thing to replenish them with, right? Alternatively, what could I use if I didn't want to use a crystalloid like sodium chloride? What could I use? Yeah, so colloids. So what would be an example of a colloid? Albumin's a good one. It's like a head of starch. Yeah, it's another one. So again, we don't use this very frequently, but for some patients who are have low serum proteins, you might use that as a replacement. But just be aware that there's a difference there between the colloids and the crystalloids. For a patient with diarrhea who is depleted intracellularly, you stated at one point that half normal saline is a good choice. Can D5 be used also, since a high percentage moves to the ICF? So basically, I had a question saying that if you had a patient who had a lot of diarrhea and say their serum sodium was relatively normal, could I just give D5W, give all that free water? Why wouldn't I want to do that? So let's say they're intracellularly depleted, right? So again, they just so D5 because it's all free water, a lot of it would end up in the intracellular space, right? So similarly with D5 half, you would still have a little bit less of it go to intracellular, but a little bit more of it would stay in the extracellular space. So the main thing here is that you'd probably use, and a lot of times, especially in pediatric patients, their maintenance fluids are D5 half. Like, so you have a kid coming in for gastroenteritis, not able to keep down oral fluids, we'll start them on D5 half. And the reason for that is because if you just gave them D5, you run the risk of diluting out their serum sodium and making them hyponatremic. So you want to give them a little bit of sodium, but you don't have to give them normal saline. So very frequently you'll see patients on maintenance fluids being on D5 half normal saline or 0.45%. That's usually pretty standard go-to IV fluids. That kind of makes sense? So again, you oftentimes do not want to give them that huge amount of free water. The only time you really are giving D5 by itself is if you're correcting their blood glucose, in which case you're probably using a more concentrated form anyway, like D25 or D50. Okay. All right, so any questions? Hopefully I kind of addressed the sodium stuff.
Your D5, are you ever going to give that to a diabetic patient?
Sometimes you will give D5 to them. So say you have like a patient in DKA, you will oftentimes give them, it's kind of interesting how they do DKA, where they will have, you give them an insulin drip, right? Because that's their baseline problems. They don't have enough insulin, right? So you're giving them an insulin drip, and then you're starting them on 2 bags of fluids. Essentially, one of them has D10 in it. I think it's D10 NS, and the other one just has NS. And so based on what their blood glucose is, you can actually start to titrate which bag is running at which rate. So essentially, if I were to run both of those at the same time, so NS by itself and NS with D10, if I run those in together, what do I have?
D5.
NS D5, right? So I basically I'm cutting the concentration of the dextrose in half. So if they need more blood glucose, I'm going to just run the D10 NS bag. If they need less glucose, I can either run the bags together, or if I need even less, just run the NS bag. So
if your blood glucose starts dropping too quickly, then we would start
yeah, because again, if I'm frequently you want to give them at least some dextrose, right? Because whenever I'm giving insulin, and we'll cover this in the endocrine section, insulin drives glucose into the cells, right? As it's supposed to. So you don't want to drop their glucose too quickly, because that can cause issues with fluid, will cause hypoglycemia, but it can also cause you worry about cerebral edema and things like that if you drop it too quickly. So frequently you'll start off with, like, say, D5NS, and then as they're dropping somewhat steadily, if it gets too quickly, then you can switch back over to the D10. I don't remember the exact rates, but usually it's like so many milligrams per hour, milligrams per liter per hour. They'll say to drop it by this much. If it's too fast, you'll switch over to the D10NS. Do you guys want to hear a joke about sodium?
Yes.
Nah.
Hyper, the one that's the hyponatremia that's related to the glucose.
Yeah. So
How do you treat that?
So your hypertonic hyponatremia, frequently those patients are going to get started on insulin drip as well. Yep. But their blood sugars are starting off like 1,000 plus, and so you don't really need to get you don't want to correct them too quickly, but you don't need to give them as much dextrose usually. Any other questions? Okay, so I will not see you guys until the next semester. So if you have any feedback, please write it down on your evaluations. Constructive things, preferably. I keep a box of Kleenexes next to me when I read that stuff. So, but yeah, anything you guys think of for next time?
Where did you guys get this?
I'm not sure. This is my first time teaching Adventist, so.
I was like 3 semesters down the road.
Oh, I have no idea. So whenever I get them, I will try to make changes for the next group of guinea pigs. So.